Hi there, my valued, highly treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, I humbly urge you to sit back and spare me part of your very precious time to share with you some of the tips which may prove useful in your line of duty. So I welcome you to part 53 of our pharmacotherapy MCQ series, Majoring in Urology. Welcome. Question number 1 reads, Mrs. G.O.Y., a Kenyan female suffering from sexual dysfunction, was prescribed flibanserin, marketed as ADI. So my question to you is, how would you advise her to take ADI? Would you recommend it be taken 30 minutes before sexual intercourse, or would you recommend medication be taken orally once daily at bedtime, or would you recommend it be taken twice daily with meals, or would you recommend the medication be taken 2 hours before planned sexual intercourse? I'll give you 10 seconds to choose the correct answer. So I'd advise the patient to take it orally once daily at bedtime. Now, flibanserin, or rather ADI, is a mixed 5-HT1A agonist cum 5-HT2A antagonist, which is indicated in the treatment of premenopausal women with acquired generalized hypoactive sexual disorder. Now, ADI should be taken orally once daily at bedtime, according to the literature insert. It is dosed at bedtime because administration during waking hours increases the risks of hypotension, syncope, and it could lead to accidental injury either through falls or otherwise, and it can also cause CNS depression. Now, because of all those reasons, it would be advisable to take it before retiring to bed. So that makes B the most appropriate choice. Let's move to the next slide, please. And the question reads, which of the statements listed below is or are true about the use of tadalafil in male patients? Is it true that it can be used for the treatment of pulmonary artery hypertension? Or is it true that it must be avoided in patients taking 5-alpha reductase inhibitors? Or is it true that it is a substrate of the CYP3A4 enzyme system? Or is it true that nitrates can be initiated safely after only 12 hours from the use of tadalafil? I'll give you 10 seconds to choose the correct answer. Both answers A and C are correct. Tadalafil, which is marketed as Cialis, is a type 5 phosphodiesterase inhibitor, which is used for the treatment of erectile dysfunction and benign prostatic hyperplasia, which we abbreviate as BPH. It is also a substrate of the CYP3A4 enzyme system, and this makes it or puts it at a risk of many drug-drug interactions. Now, due to the long half-life of tadalafil or Cialis, nitrates should be avoided for at least 48 hours after the last tadalafil dose. Otherwise, there would be gross hypotension, which could be fatal in extreme cases. Now, I would also like to add that there are no contraindications for the co-administration of 5-alpha reductase inhibitors, which are used to treat benign prostatic hyperplasia. However, alpha-1 blockers can be problematic when co-administered with tadalafil because of the high chances of orthostasis arising. Now, if tadalafil is used in combination with finasteride, for example, for BPH, the duration of therapy is usually around 26 weeks, just for your information. Let's move to the next question, please. And it reads, your clinical team is nursing an elderly adult patient with PMH over erectile dysfunction. They know he has a history of erectile dysfunction. He reports to the urology clinic after a 90-day tadalafil trial and informs the team at the clinic that tadalafil just didn't work for him, even though he administered it appropriately as per the instructions he was given. So your team did proper medication use counseling, but despite that, the efficacy is questionable. You discuss the options with this particular patient, and he hopes to try alprostadil injection. So my question to you is, which of the following is an important counseling point which should be included while educating this particular patient? Would it be an erection will last up to 2 hours with the initiation of alprostadil, or would it be that this medication should be injected into one side of the spongy tissue of the penis, running up and down the right and left sides? Or would it be this medication has many significant drug-drug interactions, so you would advise the patient to notify their physician or pharmacist of any medications they are taking prior to initiation? Or would it be inject the medication 30 to 45 minutes prior the time for a desired erection? I'll give you 10 seconds to choose the correct answer. So B would be the correct choice. This medication should be injected into one side of the spongy tissue of the penis, running up and down the right and the left sides. Now, alprostadil is an intracavernosal injection, and it's an effective erectile dysfunction medication, and in many forms of literature they quote its efficacy rates in the range of 70 to 90%, if I remember well, and they peg that to the dose. They say it's dose related. Now, the greatest barrier to using this therapy is the route of administration. That is to say, it must be injected into the corpus cavernosum of the penis, which is the spongy tissue of the penis, running up and down the right and the left sides. Now, significant patient education is necessary for appropriate use It should be injected 5 to 10 minutes prior to the desired reaction, and not 30 to 45 as in alternative D. So that makes alternative D wrong, and its effect lasts about an hour, so that makes A wrong as well. And I would just like to add that erections lasting longer than 1 hour require decreases in the doses of alprostadil. Now, the advantage of alprostadil include the fact that there are no significant drug-drug interactions. There is no renal or hepatic dose adjustment that needs to be done, so it's a fairly safe drug. So that makes answer C wrong as well, leaving us with B as the most appropriate alternative. Let's move to the next question, please. The next question reads, Mr. GH, a 69-year-old male patient, presents to your urology clinic complaining of urinary difficulties and reports a 4-month history of worsening symptoms, which include urgency, frequency, nocturia, hesitancy, and weak stream. So my question to you is, which of the choices listed below would provide the greatest chance for substantial improvement in Mr. GGH symptoms? Would it be the combination of tolterodine with duloxetine? Would it be darifenacin co-administered with fesoterodine? Or would it be pseudoephedrine? Or would it be oxybutynin? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Darifenacin co-administered with fesoterodine. Now, Mr. GGH complains of urinary incontinence symptoms consistent with overactive bladder and obstructive symptoms likely associated with BPH, in my opinion. Now, an antimuscarinic plus an alpha blocker will likely provide the most symptomatic benefit for such a patient. Now, duloxetine, which is marketed as Cymbalta, and pseudoephedrine will likely not be of benefit, in my opinion, because Mr. GGH doesn't appear to have stress incontinence. So those would be wrong choices, in my opinion. Let's move to the next slide, please. The next question reads, Mr. SBD, a middle-aged male patient, presents to a urology clinic for evaluation and treatment of erectile dysfunction. After reviewing his clinical notes, your team is hesitant to initiate a phosphodiesterase type 5 inhibitor in this particular patient. So my question to you is, which of the following issues found in the clinical notes would prevent your team from initiating a phosphodiesterase type 5 inhibitor in Mr. SBD? Would it be hypertension? Would it be leukemia? Would it be decreased libido? Or would it be stable coronary artery disease? I'll give you 10 seconds to choose the correct answer. So leukemia it would be. Now, just like to emphasize that situations which are unfavorable for the use of phosphodiesterase type 5 inhibitors include concurrent use of organic nitrates, in which it is a contraindication, or it also applies to conditions predisposing to priapism, such as anatomical deformations, the sickle cell anemia, and leukemia. And lastly, even severe or unstable coronary artery disease can cause problems in such patients. Now, the use of phosphodiesterase in type 5 inhibitors should be avoided in patients taking strong CYP3A4 inhibitors. There are major drug interactions between the two. I would like to add that stable coronary artery disease and hypertension wouldn't prevent the use of type 5 phosphodiesterase inhibitors. But I would like to underscore the fact that both could lead to erectile dysfunction. So remember that if you inevitably have to use the two concurrently in the same patient. I would also like to add that decreased libido is frequently associated with low testosterone levels, which should be addressed to improve possible secondary erectile dysfunction, but isn't a reason to avoid the type 5 phosphodiesterase inhibitor use. So I would address that issue by supplementing the subtherapeutic levels of testosterone. Let's move to the next slide, please. And the question reads, your urologist is reviewing erectile dysfunction and the mechanism of a normal erection. So my question to you is, which of the neurotransmitters listed below is associated with increasing nitric oxide production, resulting in an increase in cyclic GMP and a decrease in cytosolic calcium concentration that ultimately lead to an erection? Is it dopamine, norepinephrine, acetylcholine, or is it serotonin? I'll give you 10 seconds to choose the correct answer. So acetylcholine is the correct answer. Now I would like to add that the parasympathetic nervous system and corresponding neurotransmitter acetylcholine is responsible for stimulation of nitric oxide release via several mechanisms, which include, for example, stimulation of the endothelial cells. And what this does is it increases the cGMP, cyclic GMP, causing a decrease in cytosolic calcium. It also causes smooth muscle relaxation and increases the blood flow to the penis, resulting in penile erection. That's basically how the whole mechanism works. Let's move to the next slide, please. Mr. ADN, a male patient with low testosterone levels, is prescribed testosterone buccal system. My question to you is, which of the counseling points listed below would you include while educating Mr. ADN on its appropriate use? Would it be, if a tablet falls off after 4 hours, don't replace it. Wait until it's time for the next dose before placing another tablet on the gum area? Or would it be, the buccal tablets should be placed for 24 hours, replace the tablets at the same time each day? Or would it be, the buccal tablets should be placed on the upper gum just above either the left or the right incisor tooth? Or would it be, at the time of removal of the buccal tablets, the tablet can be thrown away, swallowed, or chewed? I'll give you 10 seconds to choose the correct answer. So C would be the correct answer. I would advise the patient to ensure that the buccal tablets are placed on the upper gum just above either the left or the right incisor tooth. Now, the testosterone buccal system is a novel testosterone delivery preparation that adheres to the upper gum area above either the left or the right incisor tooth. It is replaced every 12 hours and should be thrown away after use. So that makes the other answers wrong. I would also like to emphasize that the patient shouldn't swallow or chew this tablet at all. That makes D wrong. And if such a tablet falls off within the first 8 hours, the tablet should be replaced with another one, which should still be replaced at the 12th hour, just as the initial tablet should have been replaced. Now, if, however, the tablet falls off after 8 hours, replace the tablet and count it as the second tablet of the day. That's just a by the way. So let's move to the next question, please. And it reads, Mr. HPB, 47-year-old male patient with overactive bladder, that is with an extremely high urge incontinence, was recently initiated on a new medication which has worsened his blood pressure, causing hypertension. So my question to you is, which of the following medications could likely cause hypertension in Mr. HPB's case? Would it be solifenacin, marketed as Vesicare? Would it be mirabegron, marketed as Mybatric? Would it be trospium, marketed as Sanctura? Or would it be oxybutynin, marketed as Oxtrol, or Ditropan XL? I'll give you 10 seconds to choose the correct answer. So mirabegron is the correct answer. Now, mirabegron is a beta-3 agonist that is used for the treatment of overactive bladder, but is also associated with hypertension and tachycardia. Those are its side effects. Now, solifenacin is an anticholinergic agent that is indicated for the treatment of overactive bladder and is associated with causing, for example, the classical symptoms such as dry mouth, constipation, urinary retention, and even blurry vision that are common among the anticholinergics. Oxybutynin, on the other hand, is an antispasmodic agent that works by inhibiting the effects of acetylcholine on smooth muscles, but it doesn't target the skeletal muscles at all, and it's used for overactive bladder treatment. It is known to also show antimuscarinic activities, and those activities can lead to blurry vision, urinary retention, and even constipation. Now, trospium, on the other hand, is an anticholinergic agent that is also indicated in the treatment of overactive bladder and is associated with causing dry mouth, constipation, urinary retention, and blurry vision. I would like to remind you that overactive bladder includes symptoms such as urinary frequency, urgency, or urge urinary incontinence. Those are just by the way. Let's move to the next slide, please. Next question reads, you are making an oral presentation to a group of healthcare providers on erectile dysfunction, and one of the people in the audience asks you how vardenafil works to enhance an erection. So my question to you is, which of the mechanisms of action listed below describes the mechanism of action for vardenafil? Is vardenafil a dopamine agonist which decreases the release of prolactin from the anterior pituitary? Or is it true that it inhibits phosphodiesterase type 5, leading to an increase in cyclic GMP? Or is it a synthetic prostaglandin E1 analog which increases cyclic AMP levels? Or is it a synthetic steroid analog of 17-ethinyl testosterone which induces high androgen state? I'll give you 10 seconds to choose the correct answer. So it inhibits phosphodiesterase type 5 enzyme, leading to an increase in cyclic GMP. I would just like to remind you that vardenafil is a PDE5 inhibitor. Now we know that PDE5 normally breaks down cyclic GMP, and that leads to an increase in cytosolic calcium. It also causes smooth muscle contraction, and it reduces penile blood flow, and that results in the loss of an erection. Now, giving an inhibitor of phosphodiesterase type 5, you minimize the breakdown of cyclic GMP, and that can by extension prolong the erection. Now, just like to add that alprostadil is a synthetic prostaglandin E1. Answer C refers to alprostadil, not to vardenafil, and this analog increases cyclic AMP, which, like cyclic GMP, decreases cytosolic calcium levels, leading to smooth muscle relaxation. That can also increase penile blood flow, causing an erection. Now, both bromocriptine and cabergoline are dopamine agonists that are referred to in alternative A, and they can be used to treat hyperprolactinemia by decreasing prolactin release from the anterior pituitary. And we know that hyperprolactinemia is a hormonal cause of erectile dysfunction. Now, danazol is the one they are referring to in alternative D, because it's the synthetic steroid analog of 17-ethinyl testosterone that is used in the treatment of endometriosis, not in erectile dysfunction. So all those points make alternative B the correct answer. Let's move to the next question, please. And it reads, Mr. DTF, a 66-year-old male patient, presents to your urology clinic with a past medical history of gout, hypertension, and hyperlipidemia. He has or exhibits signs and symptoms of benign prostatic hyperplasia, which we abbreviate as BPH, and erectile dysfunction. My question to you is, which of the medications listed below would be the best treatment option for Mr. DTF? Would it be tamsulosin, marketed as Flomax? Would it be dutasteride, marketed as Avodat? Would it be tadalafil, marketed as Cialis? Or would it be the fixed dose combination of dutasteride and tamsulosin, marketed as Jalin? I'll give you 10 seconds to choose the correct answer. So tadalafil or Cialis would be the best example, because we know that it is an oral phosphodiesterase 5 inhibitor which is indicated for once daily use for the treatment of erectile dysfunction and for signs and symptoms of BPH. Now, dutasteride co-formulated with tamsulosin is a combination of an oral 5-alpha reductase inhibitor and an alpha adrenergic antagonist. Now, this fixed-dose combination is indicated for the treatment of symptomatic BPH in men with enlarged prostates. Now, dutasteride alone, which is marketed as Avodat, is an oral 5-alpha reductase inhibitor, which is indicated in the treatment of symptomatic BPH in men with enlarged prostate. Now, tamsulosin or Flomax, on the other hand, is an oral alpha adrenergic antagonist, which is also indicated in the treatment of symptomatic BPH in men with enlarged prostate. So, of all of them, tadalafil would be the best choice for the treatment of this patient. I would like just to say that C would be superior to all the others because of those explanations I have offered. Let's move to the next slide, please. And the question reads, your colleague at work requests you to give a medication recommendation for a patient with overactive bladder who has a past medical history of dementia, GERD, and hypertension. The colleague wants to select a medication that has limited side effects and drug-drug interaction potential. So my question to you is, which of the drugs listed below would you recommend? Would it be darifenacin, tolterodine, oxybutynin patch, or solifenacin? I'll give you 10 seconds to choose the correct answer. So I would settle for oxybutynin patch. Now, the transdermal delivery oxybutynin, which is marketed as diatropan, creates urinary incontinence medication that avoids drug-drug interactions and minimizes side effects other than the usual topical effects of the patches. Now, the other three choices, which are darifenacin, tolterodine, and solifenacin, in my opinion, will likely produce anticholinergic side effects in a subset of patients, such as this one, and they have greater potential for drug-drug interaction, so I would not settle for them. I would opt for the oxybutynin patch in this particular patient. Let's move to the next slide, please. And the question reads, Mr. I.A.D., a 69-year-old Ugandan man with a past medical history of type 2 diabetes mellitus, dyslipidemia, and diabetic peripheral neuropathy, presents to your clinic. He has symptoms consistent with erectile dysfunction and is asking for medication to help with this problem. So my question to you is, assuming there are no contraindications, which of the medications listed below would be the most appropriate for Mr. I.A.D.? Would it be tamsulosin? Would it be the vardenafil? Would it be metoclopramide? Or would it be doxazosin? I'll give you 10 seconds to choose the correct answer. So vardenafil is the correct answer. Now, there are several treatment options for erectile dysfunction, and those include, for example, the oral agents such as the phosphodiesterase type 5 inhibitors. You can also use intracorporeal or intraurethral prostaglandins such as alprostadil. You can also use vacuum devices and even penile prosthesis. I would like to add that the phosphodiesterase type 5 inhibitors such as sildenafil, vardenafil, tadalafil, and avanafil are common agents prescribed for erectile dysfunction, and their mechanism of action is to inhibit phosphodiesterase type 5 in the corpus cavernosum of the penis, and thus promoting an erection. Now, tamsulosin and doxazosin are used majorly to treat benign prostatic hyperplasia, and metoclopramide is used to treat gastroparesis. So that makes those other options A, C, and D inappropriate choices in my opinion. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to humbly request you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. Thank you very much for viewing it and listening to me. I sincerely appreciate your partnership and continued support and kind collaboration. I look forward to interacting with you in part 54 of our Pharmacotherapy MCQ series. Thank you very much for always being there for me.